We are live.
Good evening, everyone. On behalf of AIOS, I warmly welcome you to the 11th episode of the GuruSangam webinar series, a platform dedicated to enriching the knowledge and skills of our postgraduate students and helping them to excel. They say that a good teacher teaches not from the book but from the heart. And every episode of Guru Sangam brings together such passionate teachers who lecture on a subject of their choice and expertise. Every lecture is detailed and in depth, and this, coupled with the clinical expertise from our expert panelists, gives the PGs an excellent overview of the subject that is being covered. Today's episode is on glaucoma diagnostics and management by speakers who are all experts in their field. So, with that, I warmly welcome all our speakers, our panelists, and the audience that has logged in today. Before we begin, I'd like to acknowledge and thank our chairman, Dr. Samar Kumar Basak, who's the president of AIOS, who has been the motivating and inspiration behind this Guru Sangam program. I would also like to thank Dr. Santosh Honavar and Dr. Manoj Mathur for fine-tuning and tailoring this program to perfection. So this evening, we are privileged to have a very distinguished panel of experts, each of them with immense clinical experience and expertise in the field of glaucoma. And it is my absolute pleasure to introduce you to them. So first of all, we have Dr. Asghar Hussain Syed Naqvi, who's a distinguished cataract and glaucoma surgeon, a specialist and a head of the clinical services at Dr. Agarwal Eye Hospital, Sikandrabad. We have Dr. Bibhuti Prasan Sinha, who is professor and chief of the Department of Ophthalmology at the Regional Institute of Ophthalmology, Indira Gandhi Institute of Medical Sciences, Patna, where he is also the deputy director of the institute. Dr. Gur Satinder Singh Sir, who is professor at the Adesh Medical College and Hospital, Ambala, and a renowned glaucoma specialist. We are privileged to have with us Dr. Madhu Badhuria, who is director of the Regional Institute of Ophthalmology, Sitapur Eye Hospital. Ma'am has a vast experience as a clinician, as a teacher, and as a researcher, and it is indeed our pleasure to have you with us, ma'am. Our next panelist is Dr. Rajul Parekh. Dr. Rajul is the medical director and a glaucoma specialist at the Sriji Eye Clinic in Mumbai. He's an expert surgeon and a very avid researcher. And then we have a young, dynamic cataract and glaucoma surgeon, Dr. Vikram Jain. He heads the glaucoma services at the Prasad Nethralaya, Udupi. So a very warm welcome to all our expert panelists. We are looking forward to all your inputs and perspectives at the end of the talks. So welcome everyone. And with that, we move on to our first speaker. So our first speaker is Dr. Pradeep Kumar Saraf, and it is my privilege to give you an introduction to him. He is a consultant and medical director of the Shivam Nethralaya at Kolkata, an alumnus of the BRD Medical College, Gorakhpur. He did his MS from Calcutta University in 1984. He trained as a vitreoretinal fellow from Shankar Nethralaya in 1985-86. Then he went on to do training in lasers and fluorescein angiography at Shankar Nethralaya itself, followed by a fellowship at the St. Vincentius Hospital, Germany. And he also has a phacoemulsification training at the LV Prasad Eye Institute, Hyderabad. He was earlier attached to the Vivekanand Hospital, Calcutta, as an eye bank in charge. He has a vast clinical experience, a vast surgical experience, has done more than 50,000 cataract surgeries, including intracapsular, extracapsular, and phaco. He's also a visiting ophthalmologist at the RKM Seva Pratishthan, a non-profit making charitable institute. He's professor in the Department of Ophthalmology at the Vivekanand Institute of Medical Sciences at Kolkata. He's also been a PG and an MBBS examiner since 2015. And with that very vast clinical and teaching experience, we look forward to Dr. Pradeep Kumar Saraf's talk on visual field. So he'll be telling us the complexities of the field, and actually he'll be unraveling these complexities for us. And telling us about the visual fields, how they help in the diagnosis and in the follow-up of patients of glaucoma. So I'll stop sharing my slide and I request Dr. Saraf sir to please share your slides. Looking forward to your talk.
Good evening, Chairman Dr. Samar Basar, Dr. Tinku Bali, all the program directors and expert panelists. I thank All India Ophthalmic Society for giving me an opportunity to talk on visual fields. The visual field is the area that a person can see while focusing on the central point. It includes the area what is seen above, below, and to either side of point of focus. The normal visual field extends more than 90 degrees temporally, 60 degrees superiorly, 60 degrees nasally, and 70 to 75 degrees inferiorly. Visual field is limited by the orbital margin. Retina is a well-differentiated sensory membrane. Incident light stimulates the ganglion cell layer of retina, and axons from ganglion cell course towards the optic disc in three basic patterns. Papillomacular bundle, which arises from the macula towards the central point of the retina. Superior and inferior arcuate bundles, which come from the temporal retina, inferior arcuate, superior arcuate bundles, and radial fibers come from the nasal retina. We must know what is hemifield. It is an imaginary vertical and horizontal line drawn through macula, divides retina in nasal and temporal half, superior and inferior halves respectively. Nasal axons subserve the temporal half of the vision. Temporal axon subserves the nasal half of the vision. Superior axon sees the lower visual field, and inferior axon sees the superior visual field. Visual sensitivity is greatest at the fovea, which is seen here, and it decreases towards the periphery. The field is represented as a hill of vision, surrounded by blindness. It depends on the height and shape of normal hill of vision varies with age, general level of ambient light, stimulus size, and stimulus duration. The peaks and valleys on the islands correspond to the areas of increased or decreased vision. These contours can be mapped by the recording weakest light stimulus that can be seen at specific location in the visual field. Nerve fibers come together about 10 to 15 degree nasally from fovea and is known as optic disc, nerve head. It has no photoreceptors, so it creates a deep depression in the boundaries of normal visual field and is known as blind spot. This is blind spot optic nerve head. This is known as blind spot. It can be seen here in the hill of the vision, and perimetry also. This black area is known as a blind spot. An image formed in retina is upside down and right and left. So the blind spot is seen on the temporal side of the fixation. Visual field gives essential information about the diagnosis and progress of the disease. Field defect is statistical significant departure from smooth shape of normal hill of vision. It may be generalized or localized. Generalized defects depends on the age, refractive error, media opacity, pupil size, glaucoma, but is rarely used in diagnosis. Localized defect can be described in terms of size and depth, so it's more diagnostic. It is used in diagnosis of glaucoma, neurological diseases, and retinal diseases. First, we'll tell what field of defect we can see in glaucoma. We can have localized nerve fiber layer defect, arcuate defect, and nasal step. In glaucoma, there is structural damage to ganglion cells and their axons, causing partial or complete functional loss in the area of damaged cells. Initial damage is done to one or more axon bundles, creating a localized visual field defect or a focal defect. as seen here in this visual field. It is more common in paracentral areas, nasally and superiorly. The arcuate scotoma starts from the blind spot and arches above and below the fixation of both to median horizontal raphe. It starts from the blind spot and goes up and down towards median horizontal raphe. It starts as an isolated defect in arcuate area, forming an arching scotoma and later arcuate scotoma. Biarcuate defect is known as ring scotoma. This is ring scotoma. You can see it here. Occasionally, the early arcuate defects may connect with the blind spot and taper to a point in a slightly curved course known as cedar scotoma before progressing to arcuate scotoma. A step-like defect created where nerve fibers meet along the median raphe is known as nasal step. It is mostly superiorly. Before talking about neurological fields, you must know some important terms. Evaluating these allow for possible localization of the problem. It is unilateral defect affecting only one eye field, bilateral defect if affects both the fields. Scotoma is relative, area of less sensitivity, or absolute, where area of no sensitivity. These are normal fields, but these are early defects, more defects, and these are complete absolute scotoma. The shape of defect is important. Circular or oval affects the central vision of fixation. It may be centrocecal, affects fixations to blind spot, as in toxic neuropathy, and paracentral is near the center. Altitudinal defect. Defects which affect the upper half or lower half of the field. It's seen in extensive arcuate scotoma and in optic neuropathy. Hemianopia. Loss of half of the field is known as hemianopia. If it is less than half, it's known as incomplete hemianopia. Loss of 1/4 of the field is known as quadrantenopia. Homonymous if it is affect the same side, right or left. Here both right side is affected, so it's right homonymous hemianopia. Heteronymous affects the opposite side. It is either binasal or bitemporal. Here both the nasal field is affected. Understanding the visual pathway is imperative to detect damage along the visual pathways. Image of temporal retina goes through the optic nerve, optic chiasma, optic tract, radiation, and same side of occipital cortex, while the nasal fibers cross in the optic chiasma to go to the opposite side of optic tract and visual cortex. We must see the position, shape, laterality, and congruity to evaluate the visual field if for neurological cases. So we can detect the lesion by field defect. Lesion in optic nerve will cause loss of vision in one eye, while lesion in anterior chiasma will cause hemianopia. Loss damage in the optic tract or behind will cause homonymous hemianopia, and lesion in the center of chiasma will cause bitemporal heterogeneous hemianopia. Neurological field is characterized by vertical demarcation. This is important to detect its neurological. Visual fields can be used to detect retinal diseases and see its progression. It is rarely used. It can be used in retinal dystrophies as retinitis pigmentosa, cone dystrophy, Stargardt disease, gyrate atrophy of retina, diabetic retinopathy, etc. The earliest field defect in retinitis pigmentosa is a group of small isolated scotoma, which is about 20 to 25 degrees from the fixation. Eventually, these isolated defects coalesce to form a ring scotoma, affecting the mid-periphery of the visual field. Usually, the peripheral loss progresses and leaves a small center island of vision. Eventually, complete vision loss may occur. In cone dystrophy, there is progressive symmetrical or slightly asymmetrical central visual loss. This is associated with the macular pigmentary disturbance. The visual field demonstrates central scotoma with relative sparing of fovea. Stargardt disease may show central or paracentral scotoma. In gyrate atrophy, there is construction of visual field corresponding to the progressive peripheral retinal degeneration. The diffuse retinal ischemia associated with diabetic retinopathy would seem to make visual field assessment an ideal method for follow-up of the disease. However, visual fields are not routinely used to evaluate this retinal disease, even though the field effects may exist in absence of observable retinopathy. Now, when we see the printout of the Humphrey parameter, we see there are a lot of data and what they tell. They tell about the reliability of the test, and to interpret the result, make it reliable and reproducible. On the right side, it is given eye to test it. This is single field analysis, which is shown here, and single field analysis is written here. To compare 4 tests, we can have overview printout. It cannot consist mixture of tests run in different parameters. So in the overview analysis, all the tests done in same parameters, with same thresholds, same spot size. Then we can compare these tests, and it's easy to compare the defects of different fields. Second line tells the date of birth, and age is calculated by that. Inserting proper age is important, as total deviation pattern, GST, global indices, depend on the age. Third line tells about the test pattern used. Here is a list of some threshold test patterns used. It is central test, central 10-2, central 24-2, central 30-2, macular program, peripheral 60-4, nasal step, temporal present, and neurological 20 and 30 degree. Features of commonly used test patterns are 30-2, 24-2, 10-2, and macular program. In 30-2 and 24-2, point density is 6 degree. And in 30-2, we test 76 points. In 24-2, we test 54 points. In test 10-2, the point density is 2 degree, and we test 68 points. So it is done in cases, 10-2 is used in cases of marked field defect to assess the progress and study macular involvement. Background illumination in Humphrey field is 31.5 ASB. Higher background illumination makes the test little less sensitive. To evaluate the field, we must know about the various parameters used for testing Humphrey machine. Testing parameters are stimulus intensity, stimulus size, stimulus color, fixation target, fixation monitoring, and foveal threshold. The field analyzer uses projected stimuli, which can be varied in intensity over a range of 0.08 to 10,000 ASB. This is recorded as decibel notation that refers to retinal sensitivity. Higher the intensity of light required to see suggests a lower sensitivity of retina. The brightest light and decibel is 0. So retinal sensitivity is poor when the high intensity is required to see that. Normally in computerized static parametry, single test only stimulus intensity is changed, not the size. The advantage is that all results may be compared directly in terms of brightness. There is no need to convert results from one spot to another spot. We know that visual sensitivity is maximum at fovea and decreases towards the periphery. The sensitivity also varies normally with age, general level of ambient light, stimulus size, and stimulus duration. Humphrey Analyzer offers 5 sizes of stimulus, 1 to 5, allowing flexibility in testing patients. Here the size is mentioned. Normally, machine uses the size of 3.04 degree. It is small enough to detect small scotoma and yet is large enough to be relatively unaffected by residual refractive error. Larger size may be used if there is generalized depression and visual acuity is low. Testing with larger spots make it possible to follow highly damaged area and note any progression. Other sizes can be used in research extra. It is stimulus color is also variable. It is written white here. So normally we use white color. Blue and red color are used in special tests. The fixation is also important. So for that, we have to do fixation target. It is given here fixation target, which is central. If the person sees in the central yellow bright light in this ball, it is central fixation. A small and large diamond are located below the central spot and is used where there is central visual damage, macular degeneration, and patient cannot look at the center. The patient look in the center of the diamond found by the 4 lights. Bottom LED is the biggest, lowest point in the biggest diamond is used to test the superior 64 or superior 36 neurological field. Fixation is also very important to get the proper field. For that, we have to monitor the fixation. Fixation monitor is also mentioned here. It can be gaze track, blind spot, gaze and blind spot, both may be on and both may be off. Gaze track, this system measures gaze direction at time of stimulus presentation. Upward marking indicates that test eye deviated from fixation target at time of stimulus presentation. Higher the marking, greater the deviation, and poor is the reliability. Blind spot. The test program periodically presents the stimulus in patient's blind spot. If patient's fixation is well, he should not see blind spot. Check stimulus. If gaze and blind spot both are on, and if both are off. If both are off, the operator should monitor fixation with the video eye monitor. Foveal threshold, which is mentioned here. It is threshold value of fovea is determined in the beginning of the test. This presents stimuli inside the fixation of small diamond. This may be off or on. When foveal threshold is significantly depressed, a probability symbol appears next to it value. It also depends on proper refractive correction. Now we must see if the test is reliable or not. So what are the indices of reliability? In interpreting the test result, first thing we must know the reliability. The test is of no significance if reliability is poor. The indices of reliability are fixation loss, false positive errors, false negative error, pupil size, and refractive error. 3 of the 6 lines on the left side of page indicates the reliability of the particular test. In this test, fixation loss is 1 out of 17, fixation false positive error is 5%, and fixation false negative error is 4%. Poor fixation means poor reliability. It is seen when blind spot monitoring is on. The stimulus is shown on blind spot. If patient responds to stimulus, it is recorded as fixation loss. If fixation loss is about 20%, test is of doubtful significance, and double X appears next to the value of printout. It may also occur because of wrong blind spot plotting because of head tilt. False positive error. If the patient pushes the button to non-projected stimuli, a false positive error is recorded. If error exceeds 33% of trials, double X will appear on the printout. Reliability is compromised at false positive rates, about 20%. This happens in trigger-friendly patients. Some false negative error. Sometimes stimulus that is brighter than threshold is presented in an area which has been tested. If the patient does not respond, a false negative error is recorded. If error exceeds 33% of trials, double X will appear on the printout. Reliability is compromised at false negative rate below 20% if it suggests fatigue, inattentive, malingering patient. However, it can be seen in significant pathology also. Pupil size should be normally 3 to 4 millimeter. If it is smaller, it should be dilated because the smaller pupil will give overall depression in visual field or edge defect. Proper near evasion reflection correction should be done, otherwise get generalized depression. Testing, there are screening and threshold strategies. Screening is just for the screening and is not reliable. Threshold is a more detailed test and helps in diagnosis and follow-up. It is mentioned here, threshold test. To determine the threshold, in this machine, the initial stimulus is at intensity slightly brighter than the patient's expected threshold. If patient sees the spot, the analyzer decreases the intensity of stimulus in 4 decibel steps till the patient does not see it. It then increases by 2 decibel till patient stimulus is seen. The last value seen is identified as spatial threshold at the point. If patient does not see the initial stimulus, the intensity increases by 2 decibel till one can see it. The field analyzer is unique that whenever the measured threshold departs from the expected value for a point in visual field, the analyzer rechecks the point. The expected value is calculated from the answers at the adjacent points. The second value is printed in test results in bracket below the first one and is regarded as more accurate. These are the 4 threshold strategies which are used in Humphrey Field Analyzer: full threshold, Sita standards, fast tech, and Sita fast. Sita standard is the most common test. It is known as Swedish interactive threshold algorithm. This is the threshold method which collects twice as much information per unit time as the full threshold strategy. Thus cuts testing time in half relative to full threshold strategy without compromising test reproducibility. So patients don't get fatigued. If you full threshold, patient will get fatigued because it takes more time. The reading of the field analyzer printout. The threshold test results are printed on grayscale. which gives pictures resembling to isopters and numeric grid, with threshold levels shown in decibels. It- this is the grayscale, the first. It gives actual parameter results that were for interpretation. The grayscale provides an immediate idea of size of field effect. Normally, we don't make diagnosis on basis of grayscale, as it is not corrected for age and other parameters to be discussed later. However, it can be used in cases of gross false positive and false negative errors. It is the numerical result of the grayscale. It is the exact retinal sensitivity of selected points. It is used in cases where all zones are normal, but clinical features are highly suspicious. If the defect here is repeated and correlated to clinical defect, one may consider it. Triangle here suggests the blind spot. Total deviation plots. It is a pair of plots labeled total deviation plot. The numerical value in the upper plot represents the difference of decibel between patient test results and age-corrected normal value of each spot in the visual field. Lower total deviation plot calls probability plot. Translate the value in the upper plot into shaded symbols, which indicate the statistical significance of each decibel deviation. These are explained as probability symbols. These are probability symbols. The darker the symbol, less likely it is that field in normal location. Pattern deviation. On the right in the lower half of the single field analysis printout is a pair of plots, one above the other, labeled pattern deviation plots. They are similar to total deviation plot, except that here the StatPack has adjusted analysis for any change in height or measured field of vision caused by cataracts, small pupil, etc. To reach 24 dash field is considered 3-point near blind spots are ignored. From remaining 51 spots, 6 best sensitive points are ignored. Seventh best spot is made 0 in pattern deviation. Reducing the height of the hill of vision and deviation at other points are adjusted accordingly. Deviation is adjusted accordingly. Humphrey versus octopus. Both have similar data outputs, only differ in nomenclature and few software outputs. Now, interpreting visual fields. Shallow defect 5 decibel scotoma covering only 1 point may be considered normal because of patient's response. However, if there are 2-3 such spots in an area, then it may be of concern. This is normal field because one scattered defects is normal. Criteria to pick up early field defects in glaucoma. 3 non-adjacent scotoma in pattern deviation probability plot. 2 points must be less than P5% and 1 spot less than 1%. Criteria for general depression. When 2 eyes are compared, there is a difference in mean deviation of 1.5 decibel in 2 consecutive tests or 1 decibel in 4 consecutive tests. Last but not the least, please note, the visual field reports has to correlate clinically. There are conditions where you get field defects in normal eye or due to other ocular pathology which are wrongly labeled glaucomatous. Single field defect may not be reliable, but finding same defect in repeated field is of concern. Thank you.
Thank you, sir, for that very, very complete talk, very well illustrated with different pictures. So thank you. It was a very comprehensive talk. With that, we move on to our panelists for their takeaways, any key takeaways, any practical pearls or any words of advice that they would like to offer to our postgraduates. So we'll start with Dr. Gur Satinder Singh, sir. Sir,
Hello, am I
your
audible?
perspectives on this? Yes, sir, you're.
So the first important thing is which test to choose in perimetry. So for glaucoma, if you say that you choose a 24-2 test is the best test, where each point is separated by 6 degrees. Now the question is that even 20 to 30% patients, despite having a field defect, may turn out a normal test on 24-2 testing. So in those cases, if you think the disc is suspicious, there is a little, you can see some fiber defect is there, or you can see some notch in the disc, or it's a vertically oval disc. If there's a little suspicion of the disc being normal, despite IOP being normal, then you can have, in addition to 24-2, 10-2 test. So sometimes 24-2 may be normal, but 10-2 field may turn out to be having some defect. So now we have another test, one is that 24-2C. So which is a new test which is available in the new machines, and this test tests all the points in the central field, and along with it, it tests 10 additional points which are in the central 10-degree field. So they are, most of the points are in the superior area between in the central 10-degree field. So the idea is that in addition to 24-2 field, you get some points for the central testing. That obviates the need for testing 24-2 and plus 10-2 both tests. So, but till now, this test is being used more as a screening test. So, its clinical application is still being looked into, but it's a fairly good screening test if the patient is having any kind of scotomas in the central field. We also know that inferior fibers, they grow very close to the macula, and superior arcuate fibers, they don't go very close to the macular area because fovea is little below the midline of the central disc. So the inferior inferior arcuate fibers are the one which pass very close to the macula, and most of the times you will find defect in central field in the superior field corresponding to the infratemporal fibers. So test you should use is 24-2 because it cuts down the test time to about 5 minutes in CETA standard, and second is that it knocks out the peripheral points and gives a fairly good idea of the status of the field. In addition, you can do 10-2 or you can go for 24-2C in your test. And one more test is available now. Strategy is the CETA faster is available now because we used to have CETA fast. Now we have CETA faster, which even cuts down the test time, which can be used only in the patients who have already had CETA fast test, who are used to having the test, but you can't directly compare these tests to the CETA fast.
Thank you, sir. Excellent pointers. Dr. Rajul Parekh, would you have any perspectives on
Yeah,
this?
so as Dr. Guru Satinder said, 24-2C takes the central points, and Guru Satinder, 24-2C is a faster, Sita faster strategy only.
Yeah,
So
yes.
it finishes in 3 minutes.
Yes.
I'm not very fond of it 24-2. I do it routinely, but because it's a faster strategy, it takes some shortcuts. So ideally speaking, 24-2 is much better than 24-2C. But yes, it picks up the central points which I missed on 24-2. So 24-2 is C has definite advantage. The second more important thing to all the postgraduate, if we are learning, is to explain the patient how to do the test, because if you don't explain the patient how to do the test, we will get all sort of artifacts, and relying only on the optometrist or technician it will be a mistake, because they also don't know how half of the time. So you have to train your technician, you have to train your optometrist how to do the test. That is most important aspect, because patient's chin would be up, down, the forehead would not be touching the machine, and you will get artifact. You will not realize that it is because of glaucoma, but it's artifact. So that is the more important thing. The other important thing, of course, there are too many things we cannot discuss. But if you read the book written by Anderson, or if book is written by Patela and Anders Heil, they are the standard textbook as well as the Humphrey perimeter is concerned, that covers everything in and out. And if you want to read a short article, IGO long time back, Ravi Thomas had written article in interpreting automated perimetry. It's concise everything basics of single field printout analysis. So that would be my suggestion to the junior ophthalmologist as well as senior if they're interested in perimetry.
Dr. Rajul, what is the place of a 30-2 program in
So
glaucoma
you see, if you
evaluation?
look, ideally 24 takes care of everything. But when I was with Anders, I had asked the same question 20 years back, and he said, Rajul, I do 30 days to in every patient because I get extra point for the research analysis. But the 30 days to in some neurological, yes, it gives some extra points. But in glaucoma management, because when do the stat pack analysis, it removes the peripheral points anyway. So in most of the times, the 24 days 2 is adequate for the glaucoma management.
Thank you so much. Dr. Vikram Jain, would you have any comments?
Good presentation, sir, Dr. Saraf. And as his last slide said, correlating is the key. Every defect need not be glaucomatous. There can be various other lesions which can give us arcuate defects also. And all graduates should remember that these defects should be repeatable. Just one field with a few defects, we should not jump to the diagnosis. Make sure you repeat it and the defect is absolutely the same. That's it for me.
And when would you advise that this repetition should be done? The same day after an interval or the next day? How?
On the same day, the patient would be too tired by then.
We call it the next.
Whenever the patient is coming next within a few days or the next week or so, especially the baseline, when we are making the diagnosis, especially the baseline.
Okay, thank you. I now invite Dr. Asghar Hussain Naqvi for his comments. Dr. Asghar. Okay, so anything else? Otherwise, we'll move on to the next stop. If there's anything else that you'd like to add.
I have one personal experience.
Yes, sir.
I got my field test done and there was marked defect. But the disc and IOP was normal. I got it checked again, second time, third time, and then it came normal. So the first field defect, I think we should not consider as pathological until and unless clinically correlated.
One question that's there in the chat box is that what are the common causes for errors in the fields, so if Dr. Gursatinder Singh, sir, if you could take that. Patient related,
I think most important thing is to have a look at the retina. Sometimes we just find as a juxtafoveal kind of some lesion is there, whether some old choroiditis patch is there or ARMD. You might have a defect which looks very simulating the glaucomatous field defects. So one thing is that you must have a good look at the fundus before interpretation of the test. If a colleague of yours send you a field that, okay, what does this field say? Don't jump into any kind of a conclusion. And second is that patient, sometimes you have to train the patient initially. And as the Dr. Sraf has rightly said, the first test is never okay. So you have to have 2-3 tests till you get a reproducible test as a baseline. So till you have a reproducible test as a baseline, don't read too much into the test. First test may be very clear, maybe going according to what it is findings are, but second, third, if repeatability is there, take that as a baseline, and it has to be repeated in 3 to 6 months' time initially, and then of course after every year. And the other thing I want to say is that for neurological fields, sometimes you may need the 60-degree screening test or 20-point screening test, where you show us suprathreshold targets. And the result shown is as point seen, point not seen. So these are definitive tests, especially in pituitary lesions or other neurological lesions. These tests are very useful. That's one screening test. You can always use those tests as a screening tools for neurological patients.
Okay. So with that, we move on. Thank you for all your inputs, excellent comments and perspectives. So now we move on to our next speaker. I'll just share my slide. So our second speaker for this evening is Dr. Devang Angmo, who is an assistant professor of ophthalmology at the Dr. R.P. Center, AIIMS, New Delhi. So to give you a brief background of Dr. Angmo, she completed her undergraduate training from the Maulana Azad Medical College, Delhi, and went on to do her post-graduation from Dr. Rajendra Prasad Center, AIIMS, New Delhi. She subsequently did a senior residency in glaucoma, cornea, cataract, and refractive surgery services from RPC AIMS, followed by a DNB, an FRCS from Glasgow, FICO, and an MNAMS degree. She also did a short-term fellowship in glaucoma from the Singapore National Eye Centre, and thereafter she joined as Senior Research Associate at RP Centre AIMS. She's also worked as an assistant professor in Chacha Nehru Bal Chikitsalaya, New Delhi. She has written extensively. She has co-authored over 30 peer-reviewed research papers and has authored and edited 2 textbooks in glaucoma and has over 20 chapters in various national and international textbooks. Her areas of research include glaucoma, strabismus, and neuro-ophthalmology. She has also received numerous awards. She has received research awards and young investigator awards by various international and national societies like the World Glaucoma Congress, Asia Arvo, and the Delhi Ophthalmological Society. She has been presenting original clinical and research work as scientific papers and has been very actively participating as faculty in various national and international conferences. So Dr. Angmo will be speaking to us on lasers in glaucoma, another very important topic for the PGs, both for their exams and for their practice. So over to you, Dr. Devang, and looking forward.
Thank you, Dr. Tinku, for the kind introduction. So I think the CV that has been taken, I think it's like a very old CV of mine. So currently I am additional professor. So is my screen visible?
Yes, it's
Yeah. So currently I'm additional professor, and lasers in glaucoma is a very important topic for PGs, both in terms of exam theory and also practical wise also. So coming on to the laser, it's basically an important bridging gap between medical and surgical management for glaucoma. And sometimes for a surgeon, laser is like a savior in cases of very difficult scenarios. So just for the PGs, so laser is basically light amplification by stimulated emission of radiation. So it can be delivered as continuous wave and pulse mode. So the principle of laser is asked in the exam. So there are 3 basic light tissue interaction. The first is the thermal effect, wherein the tissue that absorbs the light, that is basically tissue containing melanin. So any pigmented tissue will absorb the light, it gets heated, and this leads to 2 effects. One is photocoagulative, second is the photovaporization. The photocoagulative effect that is seen is in cases of argon laser trabeculoplasties and also in SLTs. And the photovaporization is seen in the NDAG iridotomy. If you look into the next is the phaco-disruptive effect, which is basically delivery of an intense focal base beam onto a tissue over a period of nanoseconds, and this which causes a damage independent of any ocular pigment. So this is what we see in cases of NDAG iridotomy, NDAG hyalodotomy, and cyclophotocoagulation. And the last is the photochemical effect, which is either photoablative that we see in excimer lasers and or the PDT, that is the photodynamic therapy. So the outline of my talk, which is important in both practical as well as for theory, is that the lasers that are used for angle closure glaucomas. Lasers, second is lasers for open angle is the selective laser trabeculoplasty or the ALT, then laser in refractory glaucomas, then endoscopic cyclophotocoagulation, and lastly, the lasers in postoperative glaucoma management. So if you look into lasers for angle closure glaucoma, first is the laser peripheral iridotomy, and second is the iridoplasty. So the first and foremost thing that they ask is what are the indications for doing a NDAG PI. The first is in cases of angle closure glaucoma and in cases of primary angle closure. In cases of primary angle closure suspects, there are few indications wherein we go ahead and do laser. We do not have to do laser all patients of PACS. Then the fellow eyes of patients of angle closure glaucoma. And then we have aphakic, pseudophakic, pupillary block glaucoma, mixed mechanism glaucomas. So there are a few contraindications also for in which NDAG laser usually is not done in patients who have very marked corneal edema, a flat AC, a dilated pupil, where there is intense inflammation, where there is any neovascularization of the iris. So what is important is the technique. So the first and foremost thing is to pre-medicate the patient with 2% pilocarpine, which is given 1 hour prior to the procedure. And it is done under topical anesthesia under the cover of tab Dimox. So what is asked is the type of laser, that is Nd:YAG laser. The power that we use is 4 to 6 millijoules. The spot size is 100 microns. And because Indian eyes are mostly pigmented, so between 2 to 5 spots, we get a full thickness YAG PI. And what next question that they ask is how do you know that the laser is complete or it is not lamellar? So it is a full thickness PI. So once the laser is done, we see a liberation of pigments, a gush of aqueous, deepening of the anterior chamber. And on slit lamp, if you put the patient on the slit lamp, we can see the visualization of lens capsule, anterior lens capsule, which is seen on retroillumination. So what is important is that prerequisite is that to use a contact lens like Abraham lens, which is commonly used. So this lens is basically a +66 diopter plano-convex lens, which is decentered, and this decentered lens is basically gives magnification without losing the depth of focus. So this lens needs to be used. Secondly, we can also use the V's lens, which is a +103 diopter lens. So the advantage of using the lens is that it acts as a speculum. So you put the lens on the eye, the patient does not move. Your laser, the spot that you are giving is exactly going on to the part of the iris where you want to aim at. So it controls eye movements. That's why if everything is controlled, there is minimal corneal and retinal burns. It focuses the beam. There is magnification to that level. And it also, if there is a bleeding and you just have to press the eye with the lens, it also controls the bleeding. So these are the advantages of using the lens. Next is the sight. The sight that we are using is basically, it is in the superior quadrant, which is covered by the upper superior palpebral aperture between 11 to 1 o'clock position. And we prefer where the iris is thin, the area of the crypt, and in a peripheral placement, and we avoid 12 o'clock position. And in eyes with silicone oil, we do an inferior PI. So post laser, the patient needs to be started on either low dose steroids or NSAIDs, aquasuppressant. And if the patient is using any anti-glaucoma medication, all those need to be continued. And the IOP needs to be monitored at 1 hour, 1 week, and 4 weeks. One should also know the complications post-laser PI. The most common is the post-laser IOP spikes. So this can be managed by continuing the anti-glaucoma medications. Anterior uveitis. This is again by giving NSAIDs or low-dose steroids. Corneal burns and bleeding are more sought if the Abraham lens is not used. Cataract, again, if very high power or the lens, Abraham lens is not used. Diplopia usually occurs if you do it in the visual, not in the 11 and 1 o'clock position. You try and do it in the visual area. And there are high likelihood chances that the iridotomy may even close if it is not a full thickness PI. So next is the laser iridoplasty. So again, iridoplasty is usually indicated in patients of plateau iris. Also can be done in angle closure glaucomas. So the power that is used is 300 to 500 milliwatt. Spot size is 300 to 500 microns, and duration is 300 to 500 milliseconds. And the aim is to put the laser spots 1 mm away from the root of the iris, and putting the spot nearly 20 to 30 spots over 360 degrees, which is basically 2 spot diameter apart. It leads to flattening of the iris. So this is the UBM picture where we can see a case of plateau iris, and after the iridoplasty, the angle has just opened up. The iris has flattened out. Next is the laser trabeculoplasty. So laser trabeculoplasty is specifically done in cases of open angle glaucomas. So here a double frequency Nd:YAG QSH laser is used. So next they asked is what is the spot size? It is nearly 400 microns, and 0.8 to 1 millijoules is used, and it is 8 times bigger spot size as compared to SLT. And normally we give 50 spots over 180 degrees. And the endpoint is we see a champagne bubble-like formation. So once we get that champagne bubble-like formation, then that is the correct power, and then we start doing the laser in the rest of the quadrants. So what is the advantage is that it does not produce photocoagulative damage. So this is the spot size that of an SLT versus a small dot of that of an ALT. And again, we use the SLT lens to deliver the laser. So what is the difference is that the energy used in SLT is less than 1% of that of ALT. And the exposure time is also 0.3 nanoseconds. So basically we see that the energy as well as the exposure time is reduced. That's why the thermal damage, there is minimal or no thermal damage, and hence the side effect profile of SLT is basically minimal or nil side effects. So again, advantage is that because there's a less tissue reaction, so there's a less endothelial proliferation, so there's less IFP spikes, lesser uveitis or pars formation, and that's why long-term effectiveness is also similar to that of ALT. Complications again, transient IOP elevation can happen, iritis, late structural alterations. Glaucoma may get more difficult to control. And what is more important is that the efficacy reduces with time. It may show that 10% patients show a IOP rise with every passing 10 years. And what is more important is that all the patients may require medical therapy in future. So that should be also informed to the patients. Post SLT, the patients may be given low dose NSAIDs. Apart from that, topical brimonidine to blunt the IOP spikes. And the patients, the IOP is monitored at 1 hour, 1 week, 4 weeks, and 3 months. Then next is the lasers and refractory glaucomas. That is the cyclodestructive procedures. So if you look at cyclodestructive procedures, they can be contact, which is transscleral, that is a diode laser cyclophotocoagulation. Then we have the micropulse laser cyclophotocoagulation, and then we have the direct endoscopic cytophotocoagulation. So the indications, what I asked is, what is the indications of cyclodissective procedure? The first is uncontrolled IOP despite maximal medical therapy, high risk of failure of filtering surgeries, multiple failed surgeries, treatment for painful blind eyes. Surgery cannot be performed in view of general medical reasons. So what basically there is a destruction of the non-pigmented ciliary epithelium, and it also enhances the increased UV fluoral outflow. So this is a small video for the PGs, as in how to perform a diode laser cyclophotocoagulation, that is DLCP. We will be explaining DLCP through the transscleral route. A peribulbar block is given, and if required, augmentation with topical proparacaine drops may be required. This is the G probe, which is connected to the diode laser using the fiber optic cable. This is the foot pedal through which the laser is delivered. A protective eyewear should be worn prior to starting treatment. This is the Iridex laser machine. Although the spot size of the laser energy is fixed, however, several parameters can be adjusted, that is the power, duration, and counter. Once the machine is switched on, it is in the standby mode. Then the power and duration are set. The usual starting power is from 1500 to 2000 milliwatts, and the duration of energy is usually 2000 milliseconds. The power may be increased by 200 milliwatt steps. Then the machine is switched to the treatment mode and the cyclophotocoagulation is started. This is the Iridex medical instrument SL oculi G probe, that is the glaucoma probe. The edge of the tip is aligned to the limbus. This allows energy from the tip of the probe to be delivered 1.2 mm away from the limbus, overlying the ciliary body. After the first spot, for subsequent spots, the footplate of the G probe is slided half its width. That is, the edge of the G probe should overlie the previous spot. And similarly, around 270 degrees to 360 degrees of DLCP is completed. This is the patient having aphakia with secondary glaucoma refractory to maximal medication. The tip of the G probe is held firmly against the globe in the correct orientation. One should always note for the pop sound in the beginning. The power is increased by 250 milliwatt steps until a pop sound is heard. Once 2 to 3 pop sounds are heard, the power is decreased by 1 step and cyclophotocoagulation is initiated. The diode laser will signal the surgeon with the audio beam as well as a change in the color of the aiming beam so that the surgeon knows when the laser is active. The foot pedal is depressed for the entirety of the cycle. The laser will automatically stop after it reaches the programmed duration. We typically treat around 270 degrees of the limbus in the initial cases and leave 2 to 3 clock hours for subsequent trabeculectomy if required in future. This is the extent to be diode. So we normally treat 270 degrees, 180 to 270 degrees in one go, and 6 to 7 applications per quadrant, and we avoid the 3 and 9 o'clock positions, and we avoid areas where there is thinning or staphyloma, or where there's a trabeculectomy site or any other surgery that has been performed, like an SFI has been put, or we have to avoid all those areas of incision. And this has been mentioned already. So what is important is the post laser regime. So the patient needs to be started on steroid antibiotic drops, which has to be tapered over 1 month. Cycloplegics is very important. One has to continue anti-glaucoma medications and also have to give oral carbonic anhydrous emitters. And analgesics is also important as it is a painful cyclodestructive procedure. The patient is reviewed at 24 1 day, 1 week, 3 weeks, and 6 weeks, and thereafter 3 to 6 monthly, depending on the IOP response that has been achieved. One needs to know the complications. The most common complication is the conjunctival surface burns, which can happen if the laser power, a very high laser power is used. And if the laser power is not this thing, it can also lead to a scleral perforation, ciliary body hemorrhage, again, because of the high laser power, intraocular inflammation, hypotony, phthisis, vision loss, and postoperative pain. So our experience is that in cases it has been safe, effective, simple, with less complications. The patients need to be re-evaluated after 1 month, and multiple applications may be necessary to achieve successful and prolonged lowering of IOP. The risk of hypotony and even phthisis are there. However, it is very rare. And in children, usually they have a very short-lived effect, so it doesn't really have a long-term effect. The efficacy per se, it's short-term. So with all this, with all these side effects in mind, the micropulse laser has been introduced. So what is micropulse laser? Is that it has a duty cycle of only 31.3%. So when the laser is working, so it is on, the laser is effectively delivered only 1/3 of the duty cycle, rest of the 2/3, the power is not being delivered. So because of this, the side effect profile is definitely on the lower side. And this is a small video wherein it shows how the micropulse laser is being done. So this is so whenever laser is being done, one has to wear these protective goggles, and the ocular surface is layered with viscoelastics, and you can see that the probe is placed at the limbus and it is gently glided. So as compared to the DLCP, wherein you have to pick up the probe and put it adjacent, here you just have to glide it, and it is a 90 seconds duty cycle. So you first treat the inferior 180 degree, and then you move on to the same gliding movement is for the next superior 180 degree, and this is for a 90 seconds duty cycle. So studies have shown that both comparing micropulse versus transcleral cyclophotocoagulation, and they've noted that diode transcleral cyclophotocoagulation in both micropulse and continuous mode have effectively reduced IOP, and the micropulse mode has a more consistent and predictive effect in lowering the IOPs. And what is more important is that micropulse is being used in patients who have good central vision, wherein we are scared that the patient might lose vision, or they have a high cases of inflammation. So in those cases, micropulse have been used and a good outcome have been seen. Then we have the endoscopic cyclophotocoagulation. So this is the new mix that is in vogue. And here we have in this video, we can see that this is actually the console, the monitor, and this is the laser delivery system. And from here, the endoscopic probe is taken and it is introduced into the anterior chamber. And this is usually clubbed with phaco, so a temporal incision is sufficient. This is the 20 gauge straight endoscopic probe that is being shown. And once the anterior chamber is filled with high viscosity viscoelastic, basically the ciliary sulcus has to be filled. Then on putting the endoscope, we can see these ciliary processes as brown finger-like projections. And once the laser is delivered, we can see that there is a whitening as well as the shrinking of the ciliary processes. So this is the end point that the laser is being effective, and it is on the continuous mode. So we sweepingly do near, through one temporal incision, 180-degree can be easily done. And then you have to switch to another incision if you want to do a complete 360-degree. And again, ECP has been found to be effective in controlling IOPs. And this was a study done in our center in which ECP was done in patients who were undergoing, in patients of primary angle closure glaucoma who were undergoing phaco along with ECP in cases of advanced stages. And we found that both phaco and phaco ECP, they were associated with significant reduction in IOP along with the widening of the anterior chamber angle parameters. But at 12 and 24 months follow-up, a statistically significant reduction in IOP was noted in the phaco ECP group as compared to the only phaco group. So the IOP was more effectively controlled in the phaco ECP group in cases of advanced glaucoma. So next, laser is also a very important tool in for surgeons in cases of post-operative glaucoma management, especially like the aqueous misdirection of the malignant glaucomas, wherein one is dreaded to not touch the eye. So with the laser, one after doing giving the medical management, we can do a YAG hyaloidotomy or a YAG capsulotomy, which disrupts the anterior hyaloid face. And opens up and basically makes the entire eye into a uni chamber. Then commonly being used is the laser suturolysis. So many a times we see that patients on follow-up, the bleb is become flat, and we don't want the patient to go to the OR and at the risk of infection. So we can just take the patient to the laser room. So here we can see this is the tighter suture, and then a single NDAC laser is given on the suture. We can see the suture is broken, and we just do a bleb massage, and we see that the bleb is raised and the IOP reduces after that. So this is like a savior in cases of bleb, preventing our blebs to fail. Then lasers also used in cases of bleb reduction, wherein the blebs are basically avascular cystic. We stain the bleb with the gentian violet dye and then put the multiple spots of NDAC laser, which leads to shrinkage of laser and also inflammation, shrinkage of the bleb and also inflammation of the bleb, leading to a reduction in the bleb size. Also, in cases of early post-trab, sometimes we see that the iris getting plugged into the ostium, and because it's an early post-trab and the vision is good, we don't want to take him intraoperatively. On the gonioscopy, we can see the plugging of the iris. We just give 1 or 2 spots of laser, and then this is how it's the magic. You can see the pupil is become regular, the iris has fallen back. So this is how the laser helps. And laser also helps in many secondary glaucoma patients like iris cysts, especially post-traumatic iris cysts. So without doing any intraocular surgeries. So to summarize, lasers have an important role in glaucoma management, bridging the gap between medical and surgical therapy. So the newer lasers have either lesser power or a lower duty cycle. Therefore, the side effect profile is definitely on the lower side. And vis-a-vis the cost, which is the one-time cost of the machine. Overall, if you see, it is cost-effective and safe in the long run. Thank you for the patient listening.
Thank you, Dr. Angmo, for that very well illustrated and very comprehensive talk. I must congratulate you. Very well spoken. So with that, we dive deeper into the subject, and I throw open this topic to the panelists. So I'll invite Dr. Rajul Parekh first for his comments.
So
or anything that you'd like to add.
Devan covered everything very nicely.
Thank you, sir.
She was very clear that not in all PSCS patients the EACP is required, which is very important message for the junior ophthalmologist. I think there is nothing to add. She has covered A to Z of glaucoma very nicely in half an hour.
Thank you, sir.
Dr. Vikram, would you like to add something or any other?
Nothing really. As Dr. Rajul said, everything has been well covered and nice videos for especially those who don't have access to these lasers. The postgraduates, they would have seen it. Good one.
Dr. Gursatinder Singh, sir?
Yeah, I think Dr. Devang has very nicely covered all the procedures that are done in glaucoma. Just to have a couple of words regarding iridotomy, because
Thank
iridotomy
you,
is the
sir.
most often used procedure in glaucoma and most often done procedure. So one is about location. She has rightly said it's 11 o'clock and 1 o'clock is the best position. 12 o'clock is never chosen because obviously if there is some little bleed, which is fairly common, it will trickle down to the pupillary area. So, but in case you don't have a nice script in these areas, you can choose some other site also. But the site to avoid absolutely is the where the lid touches the cornea. Because if your iridotomy is in the area where lid touches the cornea, it will lead to photopsias, which can be very irritating for the patients. So, in case you can't find a nice script as in Indian eyes, so then you have to go for a location other than really you want to do at 11 o'clock or 1 o'clock. Other thing is one most common complication is a hemorrhage, which is very often. So what you do is you just press with the contact lens for a while, and it will stop most of the times, and ensure that patient is not on anticoagulants. And then the other thing is that you should see the evidence of patency of the iridotomy. Patency is normally we try to test it by seeing a red glow through it, which is not right. So the gush of the aqueous along with the pigment as you hit the iris, that is a definitive proof that your iridotomy is really patent and it's complete. And the other one last comment is that in case you're doing iridotomy and in the some one sitting you can't complete the iridotomy because we have very thick irises, and these if iris is very thick you may not be able to complete it, and you keep hitting it with the repeatedly hitting it with the laser, it will start getting friable kind of a thing. You can't complete. So let it remain for a week or two. The little iris atrophy will develop in that patch, and you can hit it with the one shot and complete the iridotomy. And one other thing I comment is on suture lysis. So when you're doing suture lysis, it's very important the massage has to be on the slit lamp. It is not a blind procedure because you may end up having a flat chamber if you're doing aggressive massage. So you have to teach the patient. I normally massage the patient on the slit lamp myself for a couple of days, 2, 3 days, if I don't see any filtration bleb. So, but if you're doing a massage, you have to be very gentle and you have to see that the NDA chamber is maintained at the end of the massage. I think that's all from my side.
Thank you, sir.
One
Excellent
thing, Dr. GuruSangam, if you have facility of double frequency arc, then in thick iris we can just use the double frequency to flatten out the iris, and then we can use the ND arc. That would be also a good technique.
Absolutely, absolutely. I think you can use 300 to 500 micron size shots and probably 0.2 to 0.3 second timing and low watts like 0.3 to 0.4, 5 watt energy. And you can flatten the iris and a drumhead kind of a technique around the spot where you want to hit it with the YAG laser. Absolutely right.
Dr. Angmo, I request you to just stop sharing your screen. It's still there. Yeah. So, Dr. Hussain, if you would like to add something. Dr. Hussain? Dr. Hussain, can you hear me, sir? You're muted. You're muted, sir. Oh, he's muted. So, can we unmute him? Okay, we have a question in the chat box. What is the role of selective laser trabeculoplasty, in the present era? So I'd like to ask the panelists, how many of you are doing it and what are your indications for doing this selective laser trabeculoplasty? Dr. Rajan?
So after the light trial, the Western countries, the use of SLT earlier also was high, but now they dramatically increased. So if you read the light trial, it says that in early glaucoma or the patient who are not on medication, the success of SLT is much better than patient already on medication. So if you have a new patient not on any medication, especially prostaglandin, early glaucoma, if you do the SLT, the success rate is far superior than patient already on 2 or 3 medication. So yes, SLT can be considered as a primary treatment, provided patient understands that it is not a one-time treatment. The SLT effect goes down over a period of years. They may require medication. So the counseling is more important when you do the SLT as a first line of treatment. But in my practice, SLT as primary treatment, my use is still limited. So I do use the patient on 2 or 3 medication before, if the patient is not willing for surgery in certain moderate glaucoma. But the SLT can be considered as first line. After the light trial, the results are very conclusive. Though I have my own problem with the light study, the design. But the overall, you can say that in early glaucoma, not on medication, the SLT is a good option in relation to the medical management.
What about the other panelists? Anyone's using this in their practice?
I'm not using it, but I am very close to PGI where they have the facility. So I think the SLT is useful, especially in the pregnant patient in pregnancy. So if you want to take care of glaucoma and patient pregnant, so SLT is very useful in that situation. And otherwise, SLT can take patient of one med for some time, and maybe it can be even started as an initial treatment in early glaucoma, which Western countries are doing, but we don't have too much facility of SLT around us. But it is useful. You can take patient of one med at least. But then, of course, you need a angle queries where you may not have real usefulness of SLT.
Dr. Hussain, would you like to add something? Can't hear you, Dr. Hussain.
I think he's muted.
Dr. Hussain, you are not audible. Your mic is not working.
Yeah, his mic, he's not muted, but his mic is not
No,
working.
he's not muted. His mic is not working. Do you have a hand-free kit which you can put or any other? I believe you can hear us. We can't hear you, sir.
Yeah.
Dr. Tinku, personally here we are using SLT. Again, what Dr. Rajul has said, if you use it as a primary therapy, the response is very good vis-a-vis in patients who have been chronically on medical therapy. So in case of open angle glaucomas, we have many apprehensive patients who don't, who have the fear of surgeries. We have given them SLTs and they are doing very well for nearly 4-5 years. What is more important that we have seen in our center was that patients in whom we are frequently doing SLTs is patients of post-VR surgery glaucomas, which are usually refractory. So these glaucomas, they have high pigmentation, and we have done SLTs in these patients, and nearly 40-50% of the patients are controlled. So because doing a trabeculectomy or doing a tube is, it's more of a challenge and more complications versus doing SLT. And we have repeated these SLTs over 3 or 4 years, and these patients are following up now for 9 and 10 years on 2 or 3 medications, and they are not progressed to that level. So in these patients, we have seen the effect of SLT to be very more than optimal.
So in these type of patients, would you go in for a SLT or for a diode laser cryoablation? Diode laser ablation.
So nowadays, because the surgical profile and everything, patients have good visual potential. You always give SLT as the first, and most of the patients, they usually respond to SLT, and we then continue them on medications. And whoever become refractory, we then go ahead and we have to do diode laser.
If they have potential, we can still do the tubes before we consider the destructive procedure.
Yes.
Ma'am, am I audible?
Yes, yes, you are.
Ma'am, just wanted to add one point. Like many a times when we do YAC PI, we get across white senile arcus or sometimes pannus. So in that cases, what I have learned over time is that if we switch to red-free light, we can see that aiming spots very well. So that helps in focusing the energy. In addition to the Abraham's lens, which ma'am has told about for better focus of the energy source.
So Abraham lens, even in arcus or vascularization, it has a very good view. So it has never, given.
And if we switch to red free, it helps us see the aiming beam much better, aiming for spots much better.
Thank you so much. So with that, we'll move on to the third talk of this session. I'll just share my screen. So it's my pleasure to introduce Dr. Gazella Bruce Varjari, who's an assistant professor of ophthalmology at the Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital at New Delhi. So to give you an introduction to her, she's an alumnus of the Guwahati Medical College and went on to do her post-graduation from the ESI Hospital at Basai Darapur, New Delhi. She then did a senior residency at the RP Center, AIMS. She's also worked as a glaucoma consultant at the LV Prasad Eye Institute, Hyderabad. She's written extensively and has 20 publications in peer-reviewed journals to her credit, as well as book chapters. She has been a national and state talent search awardee, and she's also the member of the editorial review board of the Journal of Therapeutic Advances in Ophthalmology. So Dr. Gazella will be covering the topic of newer drugs in glaucoma. So over to you, Dr. Gazella.
Thank you so much, ma'am, for the introduction. So I'll just share my screen. So I'll be talking about newer drugs in glaucoma. So I have no financial disclosures to report. So these are the initial available drugs, which we all know. So initially we had started with only having cholinergics like pilocarpine. Then we went on to have beta blockers. Then later on, prostaglandins, alpha agonists, carbonic anhydrase inhibitors came. So as the years pass, the evolution of glaucoma treatment also keeps changing. So that's why my talk today is on newer drugs in glaucoma. So the outline will be, first we'll talk about the mechanism of action of these drugs, the efficacy, side effects of each drug, and what are the newer drug delivery systems. And nowadays, many of us are using this preservative-free drugs. So the goal of treating glaucoma is not only to reach this target IOP, but we also have to see the quality of life of the patient. So we are not treating only the eye pressure or the optic disc or the visual field. We have to treat the patient as a whole. So when we come to efficacy of AGMs, we can see here that the most efficacious, of course, is prostaglandin analogs, coming down towards cholinergic agonists having 15 to 25%. But when we add any two drugs, their efficacy will never be added. So we also know that with the present drugs, there are so many side effects, as you can see here. Hyperpigmentation from the use of many years of prostaglandin analogs to the blepharoconjunctivitis seen here due to brimonidine. So why do we need newer drugs? Because many times patients who have systemic illness or who are allergic to the present glaucoma medications have no option other than surgery. And we also need neuroprotective agents because the neural damage due to glaucoma, we all know, is irreversible. And also we need preservative-free drugs. So first we come to Rho kinase inhibitors. They inhibit ROCK or ROCK, Rho kinase. So this ROCK inhibitors will inhibit ROCK1 and ROCK2. And these are enzymes belonging to the family serine threonine kinases. And these are involved mainly in regulating the shape and movement of cells by acting on cytoskeleton. So if we inhibit this, then that means that there will be opening up of the trabecular meshwork. So they are shown in many studies to have increase in aqueous outflow. They have some neuroprotective effect also. And they have also been shown to reduce the scarring in bleb post-trabeculectomy. So first we talk about Netarsudil. This was developed by Erie Pharmaceuticals and it got FDA approval also for POAG and ocular hypertension. And it shows IOP lowering by 3 mechanisms. As seen here in this diagram, it acts on all the mechanisms except, of course, uveoscleral outflow. So it lowers episcleral venous pressure, it causes aqueous suppression also, and decreases the and increases the outflow. Then in the same group, we have Ripasudil, which was developed by Kowa company, and it got PMDA approval in September 2014 for POHG and OHTN. So it is metabolized by corneal esterase to netarsudil M1, and it will remain locally and it will not really go systemically. It has a long elimination half-life and 12 to 27 hours. That's why we give netarsudil only once daily, and it has a steady state concentration of 18 days. So 2 phase 3 clinical trials have compared the safety of netarsudil to timolol in patients with high IOP. These are called Rocket 1 and Rocket 2. So in Rocket 1, when it was compared to timolol for 3 months, it was shown to be non-inferior, and it had almost similar IOP lowering as compared to timolol, and that too with an OD dosing. So there was another phase 3 trial which compared netarsudil OD and BD with BD timolol, and again here it is shown that OD was also non-inferior to timolol with no additional adverse effects. Then Rocket 4, here they did IOP reduction between netarsudil OD with BD timolol in 3 and 6 months, and patients who were not already on treatment naive patients. And also these patients had a higher range of IOP. So they wanted to see in higher IOP. Again, it was shown to be non-inferior to timolol. But the only sad aspect of netarsudil and the Rho kinase inhibitors is they do have side effect of conjunctival hyperemia. Many patients will come back complaining that their eyes have become very red. So this is due to the ROC-mediated smooth muscle relaxation, which causes this hyperemia, and very, very high rate of hyperemia is there, 47.9 to 60.6%, which is very much higher to latanoprost or timolol, and many patients had discontinued the drug due to hyperemia. Also, subconjunctival hemorrhage has been shown to occur in up to 5 to 19%, also higher than latanoprost and timolol. And as shown by many case reports now, it can cause cornea verticillata, which is usually visually insignificant and resolves after you stop the drug. Same with reticular epithelial corneal edema, as seen in this photo here. This also resolves after cessation of the drug. So ripasudil also similar side effects, having conjunctival hyperemia, allergic conjunctivitis, blepharitis, and also punctate keratitis. Then we move on to the next drug, which is latanoprostin Bunod. This was developed by Bosch and Lomb and approved also by FDA in 2017. And it comes as a 0.024% solution. And it has nitric oxide donating prostaglandin F2 alpha analog. So after you put it into the eye, it is metabolized to latanoprost acid and butane diol mononitrate. And this is what releases the nitric oxide. And nitric oxide acts by relaxing the trabecular meshwork cells, which will increase the outflow of aqueous. And then on top of that, there is extra latanoprost acid, which will increase the aqueous outflow via the uveoscleral pathway, like other prostaglandin analogs. So studies have shown that after instillation, it will lower IOP at 1 to 3 hours, and the effect will be there up to 11 to 13 hours. So here also many phase 2-3 trials have been conducted. This is a phase 3 trial, Apollo, where it was compared to timolol, 3 months follow-up, and it showed that it lowered IOP at all time points, and also there was more than 25% reduction of IOP. Another phase 3 trial, Luna, also showed that it has more than 25% reduction in IOP, and with the pooled analysis of both of these trials, it showed that IOP can go down up to less than 18 mm Hg, and this is sustained up to 12 months. But similar to prostaglandin analogs, it has side effects of hyperemia, irritation, or eyelash growth, hyperpigmentation, but a very small discontinuation rate. Then comes the fixed dose combination of netarsudil, a Rho kinase inhibitor, and latanoprost. This was developed by ARI Pharmaceutics and approved by FDA in March 2019, also again for OHG and OHTN. And there was this phase 3 Mercury 1 and 2 trials, which showed that there was more than 30% reduction in IOP as compared to their individual components. Even this is the percentage reduction, and this is the absolute reduction. Again, showing here that it is decreased more in the combination as compared to its individual components. So it will have side effects of both the drugs then, like conjunctival hyperemia, corneal vitelliculata, and conjunctival hemorrhage, and pain on instillation. So there are a few more ROCK inhibitors which are still undergoing phase 1 and phase 2 trials. So coming to the newer drug delivery systems, why do we need drug delivery systems? Because glaucoma patients have to put drops for their whole lifetime. So we don't know about the compliance. So that's why we want to use a drug delivery system to reduce the dosing frequency for compliance issues, to improve the adherence, and to also ensure that they are putting the drop and getting the efficacy of the drug by increased bioavailability from the drug delivery system. So there are so many which are still under animal trials, and some human trials also have been done. So first we go to the punctal plugs. So there is this OTX-TP, which was supposed to deliver travoprost to the ocular surface via an intracanalular punctal plug for 2 to 3 months, and then it gets resorbed by itself. Another one was Evolute, which has been tested for latanoprost. But unfortunately, they did not fail to meet the phase 3 endpoint. Contact lenses also, which can elute glaucoma drugs, have been studied. For example, there was this latanoprost eluting contact lens studied in glaucomatous monkeys. This also showed to be as effective as daily dosing of latanoprost eye drops. Then there was this study where they tried to improve the release of the drug timolol. Here it was shown that using different kind of molecules, you can improve the release of the drug timolol. A GO contact lens, if it is used, timolol will be released more slowly as compared to a normal timolol soaked contact lens, as seen from this graph. So apart from contact lens, we have drug eluting rings, which can be placed in the fornix as seen here. So it will rest on the surface of the eye and it will keep eluting the drug. It was shown that the retention rate of this ring is around 90%. So it stays in the eye even up to 6 months. And patients reported that they were comfortable with the ring. They did not have any foreign body sensation. So this bimatoprost ocular ring underwent a phase 2 RCT, which was used to compare it to timolol. But unfortunately, non-inferiority definition was met only at 2 out of the 9 time points. That means it did not reduce IOP as much as timolol. And also there was a waning effect, possibly due to prostaglandin receptor sensitization. Then we have this gel forming drops. This is also similar to a ring where it is kept in the fornix, and this is supposed to elute drugs like bimatoprost. But the disadvantage was that a burst effect was seen where 30 to 40% of the drug was released quickly, suddenly on initial placement in the fornix. Then we come to the bimatoprost micro implant, very, very small implant, as you can see here, which is placed intracamerally. This was approved by FDA on March 5th, 2020, and it releases bimatoprost up to 90 days. So phase 1 and 2 studies have already shown that it is non-inferior to timolol. IOP can be reduced up to 30%, and there is efficacy in those patients who have undergone glaucoma surgery also. Then we have the iDose TR, which is for travoprost. Here there are two types of implants, the fast eluting and the slow eluting. In the phase 2 trial, both these types of uh, implants showed non-inferiority to timolol, although one patient had developed endophthalmitis, and it was also shown that the hyperemia was lower to topical treatment of travoprost. Other implants which are still being studied are Envisia, which is also a travoprost releasing implant. So one of the latest ones is Spyglass Pharma, which is being developed by Spyglass System. It is an intraocular lens implant. So they will just do cataract surgery and implant this IOL. Animal studies have been done. One human study was done in South America, which showed that there is up to 45% IOP reduction up to 9 months. And now they are doing enrollment in phase 1-2 trials in the USA. So gene therapy, of course, this would be the ultimate treatment for glaucoma, but we still have a long way to go. Many studies are being performed again on animal models using viral vectors like AAV. So as you can see here, so many molecules are being studied both for IOP reduction and also for RGC neuroprotection, but still it is a long way to go. So many of these gene therapies are targeting trabecular meshwork, the ciliary meshwork, and the retina, means retina ganglion cells for neuroprotection. So in the trabecular meshwork, mainly they are targeting genes which are involved in Rho kinase, like we talked about nitarsodil. So these genes should inhibit Rho kinase and lead to relaxation of the trabecular meshwork. And in the ciliary meshwork, they will target the metalloproteinases, which will again also allow for increased uveoscleral outflow. In the retina, we have all these molecules like CNTF, TNF alpha, all for neuroprotection. So many of them are in preclinical studies where they are just doing studies in the lab. Then we come to preservative-free, or we can call them bag-free, glaucoma drugs. So there was a study which compared preservative-free and preservative-added drugs in patients, and they were asked about ocular symptoms, and the patient was examined for any palpable signs, conjunctival signs, corneal signs, and as you can see here, all the preservative-free medications, patients had a lower rate of ocular symptoms, even palpable signs, conjunctival signs, and even corneal signs. Then here, they wanted to substitute timolol with a single daily instillation of non-preserved beta blocker. So all the patients here have reported lesser irritation, dry eye, visual difficulties, or even the eyelids being stuck together. So if we talk about preservative-free topical formulations, we have either bag-free or we have completely preservative-free, or as they call them, self-preserved formulations. So what is bag? Bag is added to preserve the drug which we are using. It has a detergent effect. So therefore, it has excellent antimicrobial activity, but it also causes ocular surface issues. Then we have purite and Sofzia. Both act by oxidative stress, and they have less conjunctival inflammation and also corneal toxicity. So Sofzia has borate, zinc, and sorbitol, and once it touches the tear film, it gets inactivated by the enzymes present there. Same for purite, it's a stabilized oxychlorocomplex. On light exposure, it dissociates into non-toxic natural tear components. So this is just a list, small list, which was compiled by an ex-colleague of mine of the preservative-free AGMs which are available. Of course, sadly, Saflutan S is not available anymore in India. And these are a few of the combination drugs. And these are the drugs which use preservatives other than BAK. And this is also a list which I have recently compiled. So why do we require preservative-free or bag-free glaucoma drugs? And who are the patients who require it? So it is mainly patients who have any dry eye or ocular surface disease. So this would be any newly diagnosed glaucoma patient who has a pre-existing ocular surface disease. In very elderly patients, they also have dry eye. Younger patients, because they need lifelong treatment. In cases of pediatric and juvenile patients, because they will require surgery and you don't want the conjunctiva to be very inflamed. All those who are at risk of getting dry eye, like collagen vascular diseases, post-corneal refractive surgery, any drugs which, if they are using, which cause dry eye, and pre-surgical patients. Nowadays, many glaucoma specialists are switching the patients to preservative-free glaucoma medications before planning them for any glaucoma drainage surgery. Also, post-menopausal women contact lens use, and if the patient has to use multiple drugs. So we are still lacking in many fields in this regard. We still don't have any comparative studies about preservative-free and preservative glaucoma medications, whether they are as efficacious as preservative-free added medications. And we still also don't have any health economic studies to assess the cost effectiveness of these preservative-free glaucoma medications. Thank you.
Thank you, Dr. Gazella, for that very informative talk. Just a question in our chat box. Is the latanoprostene Bunod eye drop available in India?
No,
And any of those devices that you talked about, the sustained release devices,
no,
are they?
not
None of
really.
them is still. Okay. So with that, we move on to our panelists for their comments. So, Dr. Hussain, would you like to start? Anything that you'd like to add or your experiences with these drugs?
Among rock inhibitors, what I found was ripasudil had lesser hyperemia and the microcystic edema compared to netarsudil, especially the hyperemia. So, and I feel that when we have to add on the maximum medical therapy, it is one of the good drugs to add on. And preservative-free drops, as Dr. Gezel has mentioned, like definitely have an advantage even if we ship them preoperatively, at least for 2 to 3 weeks. We'll have a healthier conjunctiva when we are planning to operate on these patients. So other than that, we are awaiting for the other novel techniques and the drug-eluting devices to come to India.
Thank you. Dr. Gursatinder Singh, sir?
I think Dr. Gazella has nicely covered all the new innovation, new drugs that are there in the market and they're coming. So I think I don't have much to add to that. That's wonderfully covered.
Thank you, sir. Thank you.
Dr. Rajul, which one do you think will be the next innovative drug to come to India, that you all are waiting for? Any such?
So the Bunod will come in market. The Ropresa, the combination of letasudil plus latanoprost also will come in market. The issues is the netasudil definitely has the corneal side effect, and whether it's netasudil, ripasudil, both have corneal side effect, especially the reticular honeycomb corneal edema. They are reversible, it's good thing, but the both causes, especially if the patient is on endothelium is poor. So if the patient has a complicated cataract surgery or other problem in the past, they are at the risk factor. More importantly, from the glaucoma surgeon perspective, all these drop causes severe corneal conjunctival inflammation. So the success of glaucoma surgery reduces drastically if the patient is on multiple medication. So I would like to have patient on multiple medication avoid surgery, but at some point in time we have to see that what is the risk benefit ratio, and if I have to give more medication and reduce the success of glaucoma surgery, so if the patient is on 3, 4 medication, adding fifth medication is not going to help much, where the benefit is much less compared to the risk of failure. So I during the COVID time I use extensively the netasudil and ripasudil, but my use is very limited. The implants at this point in time, FDA has not approved even more than one injection. So if I have to give Diresta every 3 to 4 months, it's not worth it. So in that case, the medical management, the drops is the choice. The nanotechnology, yes, nanotechnology will definitely have a huge impact in next 5 to 7 years. The only thing we don't know, because they are a modified molecule. So whether they will come with a different kind of side effects, we have no idea. So we have to look that into the future, but the nanotechnology will definitely change the IOL with the drug releasing devices, the micro implants with the drug releasing devices, and the devices will come with the drug. We can change it, so the device stays there. We just have to refill the drugs like that. So those things will definitely be in next decade. So I think that we'll have a fantastic, the adherence issue will go down, because if you can give the implant where patient doesn't have to put the drops, and that work for 4 to 6 months, and then again you just refill. So those things will be there in next few 5 to 7 years. I'm looking at it.
Thank you. Dr. Vikram, do you use these Rho kinase inhibitors in your practice? And if so, then what has been your experience?
It's just that the hyperemia is a limiting factor. A lot of them do have this immediate hyperemia. They come back within a week complaining about their redness, and the honeycomb epitheliopathy also is very common. Regarding the other parts of the medical management, I'm more and more shifting to preservative-free therapy because now the cost of these preservative-free medications are drastically fallen down compared to 3 years back. Therefore, more and more patients, I'm putting them on preservative-free therapy just to avoid the side effects of the preservatives.
Right. Thank you. Thank you so much. So we are left with one talk, the final and conclusive talk, and that will be by Dr. Techi Dodumtara. So Dr. Techi is a glaucoma and cataract consultant at the Sri Shankar Deva Netralaya, Guwahati. He's fellowship trained in glaucoma from the Arvind Eye Hospital, and he's an expert at doing advanced glaucoma surgeries like MIGS and glaucoma valves. He's also an expert at trabeculectomy, combined surgeries, congenital and non-penetrating glaucoma surgeries. He's had a stint at the Arvind Eye Hospital where he was a consultant. He has multiple research publications in premier ophthalmology journals, and he's been a speaker at national conferences on cutting-edge glaucoma treatment. So this evening, he'll be talking on glaucoma in pregnancy. So over to you, Dr. Techi.
Thank you, ma'am. Good evening, everyone.
Yeah, please share your screen. So I request the audience to please send in their questions or any doubts, any comments in the chat box. We'll take them up at the end of the session.
Ma'am, is my slide visible?
Yeah, you can make it full screen. It's visible. Please make it full screen. Yeah. Yes, it's good to go.
So my talk is on glaucoma in pregnancy. So there's some issues. The slides are overlapping.
Yes, can you just move the slides, doctor?
Yeah, wait. Yeah, I think, yeah, just, yeah, no, it's overlapping.
Actually, I think there is a. Yes, now it's visible. I think the first two slides have got overlapped.
Yes. So just I'll start. Basically, glaucoma is not a single disease process, but a group of disorder characterized by progressive optic neuropathy, resulting in a characteristic appearance of optic disc and specific pattern of irreversible visual field defect that are associated frequently, but invariably with raised intraocular pressure. So actually, the slides are overlapping, but what I had, as for the epidemiology, it was shown that it shows that um, like there are 2 to 3% of glaucoma prevalence in age above 40 years. And in one study, in Japanese study, has shown that the in age group of 15 to 44 years, the prevalence of glaucoma in among the women was less than 1%. And similar study in German study reported that it was about 0.16% in age group 18 to 40 years. And out of that, 49% was female. So why the glaucoma in pregnancy is complicated and difficult to treat? So it is because first is the age and the type of glaucoma. Usually the age of presentation is less than 40 years, and the type of glaucoma that presents is, it could be pre-existing glaucoma. Originally begins with a child, like congenital glaucoma, anterior segment dysgenesis, or glaucoma secondary to uveitis or diabetes. And yes, there is a risk of vision loss in mother with potential harm to the fetus and newborn because of the adverse drug because of the anti-glaucoma and anesthetic drops and surgery. So the physiological changes in woman and fetus. So here we are dealing with two different physiological spectrum at the same time. And yes, because of the low incidence, the research, we don't have a proper protocol with a proper research to set a treatment protocol. So let's just have a look at this, at the physiology that a woman goes through during the pregnancy. There are hematological changes, cardiac changes, renal changes, and respiratory changes, and alimentary changes, endocrine, and then like skeletal changes leading to joint laxity and postural changes. So ocular changes in pregnancies are external changes, changes in cornea and tear film, changes in lens, changes in visual field, and changes in intraocular pressure. So the external changes that occurs is decrease in conjunctival capillary, increase in conjunctival venules, and increased pigmentations around the eyes. And also the patients sometimes tend to have unilateral ptosis, which occurs because of the edema of the levator aponeurosis. But all these things slowly resolves with the time in postpartum period. So tear films and corneal tear changes. So pregnancy can affect the tear film physiology and dry eye. It changes the tear film composition changes. There is decreased corneal sensation, which occurs in the third trimester, and mechanism probably is because of the increased corneal thickness due to the edema. And there is also increase in corneal curvature and stiffening during the postpartum period during breastfeeding, and it ceases once the breastfeeding is over. So there is contact lens intolerance, Krukenberg spindles because of the hormonal changes, and lens changes like accommodative insufficiency or paralysis, and altered refractions, that there is a myopic shift. So visual field changes, which can be seen during pregnancies, are bitemporal loss, concentric constrictions, enlarged blind spots. This occurs basically because of the enlarged pituitary, which affects the chiasma. And these are completely reversible during the postpartum period. So IOP changes occur in pregnancies because of increased aqueous outflow, decrease in systemic vascular resistance, decrease in episcleral venous pressure, generalized increase in tissue elasticity, and decreased scleral rigidity. This sum up with the decreased IOP, and which persists for several weeks during the postpartum period. So why the fetus is at the risk when we are treating a glaucoma, when we are treating a lady in a pregnancy state? So first is because a low molecular weight, which is if it is less than 700 dalton, it uh, passes through the placenta and enters the fetal circulations. And all the anti-glaucoma medications we have that has a molecular weight of 90 to 390 daltons. So it can easily cross the placenta and enter the fetal circulations. And another thing is that fetus has a smaller blood volume. So the drug concentration reaching the blood will be more. And again, the fetus has immature hepatic and kidney system. So the metabolism and excretions are not well developed. Another thing is like the excretion goes into the amniotic fluid. So let's see the story of intraocular pressure and pregnancies. In general, there is a decrease in intraocular pressure during the pregnancy, and it persists for several weeks postpartum. So IOP decreases gradually throughout pregnancy by up to 10%, with this reduction being most marked in third quadrant. And it has been shown that the IOP decreases more in multigravida patient as compared to the primigravida. And there is reduced diurnal IOP variations also. The patients with ocular hypertension also tend to have reduced IOP during pregnancies, but approximately 10% experiences IOP elevation and progressions of the disease. So we should remind the patient that this IOP reduction is transient, and they should stick to the anti-glaucoma medications or the treatment after the in the postpartum period. So what are the what are the factors that helps in reducing the intraocular pressures during the pregnancies? The first is the hormonal storm, then other causes. Hormones like beta-HCG, progesterone, and estrogens are involved. So let's look into the hormones, prominent hormones that are involved, like estrogen, progesterone, and relaxin hormones. The progesterone hormone has dilator effect. This vasodilator effect provides decrease of arterial pressure and thus cause reductions of the aqueous humor productions. And progesterone, it causes uvascular outflow, increases the uvascular outflow, and acts as a glucocorticoid receptor antagonist in outflow pathway apparatus and inhibits the ocular hypertensive effect of the endogenous steroids. And relaxin hormone has a softening properties. It induces elastic changes in collagen, hence decreases the corneoscleral rigidity as well as rigidity of Schlemm's canal and trabecular meshwork, and hence decreases the IOP by diminishing the aqueous productions and enhanced outflow. And other causes are there is decreased, generalized decrease in the peripheral vascular resistance and upper extremity of venous pressure, which in turn leads to decrease in the episcleral venous pressure and increases outflow facilities. And maternal metabolic acidosis also aid in lowering the IOP. So it has been found to have a 3%, like CCT tend to increase by 3%, that is 16 micron, which is induced by estrogen, by upregulations of RAS and systemic water retention, which leads to corneal fluid retention and thus thick cornea. So the management options we have in pregnancy in glaucomas, first is yes, medical management, then laser, then surgical management. So medical management, it's a difficult and very challenging conditions in this scenario. The main challenge is to maintain the critical balance between the drug efficacy in terms of IOP control and its safety to the fetus. As again, there is none of the anti-glaucoma drug has been proven to be absolutely safe in this group of patients. Relative safety of drug has been outlined by FDA according to the pregnancy categories. So this is a chart where the medication has been categorized based on the teratogenic risk in the fetus by FDA. So for IOP lowering medications, none of the anti-glaucoma drugs are categorized under group A, which is deemed safe. Only brimonidine eye drop falls under category B, which is deemed possibly safe. And rest of the medications comes under category C and D. And the antimetabolites that we use in glaucoma surgery comes under category X, which is contraindicated in pregnancies. So in addition to that, we have an issues with the preservatives, like most common being bench alkyl chloride. It can disrupt the tear film and subsequent ocular surface disturbance. Type 4 hypersensitivity reaction and phytotoxicity has been found in animal study with higher doses. So let's look into the anti-glaucoma medications and their problems. First is prostaglandin. We have latanoprost, travoprost, bimetoprost, teploprost, and latanoprostene bunoid. So these medicines decreases the intraocular pressure by uvascular outflow and increases trabecular mesophageal outflow. But the problem is that it crosses the blood-placental barriers, stimulates the uterine contractions, which can lead to premature labor and spontaneous abortions. And it also has luteolytic activity and release oxytocin. Low birth weight is found to be more common with latanoprost use, so these medicines has a reasonable option during lactations. Now the beta blockers. We have timolol maleate and timolol hemihydrate as non-selective beta blockers and bitoxolol as a selective beta blockers. With these medications, we face problems like it causes fetal bradycardia, arrhythmias, lethargy and confusion, and depression in mother, and growth restrictions in newborns. And it has been considered under Group C. So once daily topical timolol of 0.1% gel has been suggested as a safer alternative during pregnancies. Bitoxolol, though it's a selective beta blockers, but its concentration is found to be 3 times more in milk than the plasma. So that's why breastfed babies of mothers on beta blockers should be monitored for the signs of beta blockade, especially those with pre-existing cardiopulmonary disease. So the symptomimetic drugs as brimonidine, clonidine, and apraclonidine. Brimonidine tartrate is the only topical glaucoma medications classified as Group B. But the problem with this medication is that it crosses the blood-brain barrier, and it might cause central nervous system depression and apnea in infants, and it also secretes in the breast milk. The carbonic anhydrase inhibitors, we have like oral carbonic anhydrase inhibitors and topical carbonic anhydrase inhibitors. The problem associated with this medicine is that like case report has shown to have a fatigue, like topical drops causing fatigue, metabolic acidosis in impaired renal function patient. And also animal studies have shown to have causing low birth weight and birth defects, and sacrococcygeal teratoma and transient renal tubular acidosis in case of oral acetazolamide use. So carbonic anhydrase inhibitor is better avoided in the first trimester of the pregnancy. Now parasympathomimetics. The problem with this medicine is the intolerance and documented teratogenic effect in animals. It has been shown to cause hyperthermia, seizures, restlessness in neonates. So better avoid in third trimester and postpartum period. Now newer drugs like rho kinase inhibitors like ripasudil and natarsudil, which has been categorized under Group C. Mainly they decrease IOP by increasing trabecular outflow, but the problem is natarsudil especially is found to have a tocolytic effect. Again, because of the diverse target of action, the natarsudil can cause possible fetal malformation and demise. So better to be avoided in first trimester of the pregnancy and during the breastfeed. So how to reduce the side effect is one thing that can do is to minimizing the systemic absorption of the drugs, which can be done by nasolacrimal occlusions, punctal plugging, eyelid closure, dotting away the excess drops. So NLO and eyelid closure for 5 minutes causes reduction of at least approximately 60% systemic absorptions. And installations of drop after breastfeeding the baby. This can be done because it has been found that after instilling the drops, the maximum amount of drug concentration found in breast milk is from half an hour to 1 hour 20 minutes after the installation. So the laser management, it is a safer option in terms of safety to the mother as well as the fetus. It's non-invasive, non-infiltrating anesthesia. No infiltrating anesthesia is needed. No risk of systemic toxicity. So it can be done in a sitting position. So the risk of postural hypotension due to vena cava compression is omitted. And it can be offered as a sole therapy or adjunct therapy. Laser peripheral iridectomy and laser traboplasty are safe for treatment and prophylaxis of acute angle closure glaucoma in pregnant women. So the options available are SLT, ALT, LPI, laser trabeculoplasty, micropulse CPC diode. But the problem with this laser treatment is it is a reduced efficacy in case of young patients and secondary glaucoma. And IOP lowering in laser treatment, especially micropulse, takes time to work. So incisional surgical options. The surgical options in case of pregnant women should be considered as a last resort. And it should be considered when the disease is progressive and IOP is not controlled with maximum medications or laser treatment. So better it should be deferred in the first trimester. The second trimester is relatively safer for surgical options. But the problem associated with the incisional surgery in this condition is the anesthetic concern, postural concern, teratogenicity of antimetabolites and post-operative medications. Then problems related to gastroesophageal reflex and difficulty in intubation in pregnant mother. Then MMC and 5-fluorouracil, which we use in glaucoma surgery, are contraindicated in pregnancies. Then there is a relative higher risk of failure because of the younger patient age and contraindications of antimetabolites. The risk of preterm labor or abortion is increased with surgery during pregnancy. So the options are trabeclectomy without pharmacological adjuvant or with ologen, GDDs and MIGS like bang, iStent, suture, trabeculotomy and others. So MIGS in pregnancy has a hope that it will do better in this scenario because it's an ab interno approach with short surgery time and rapid recovery. At least modest efficacy, extremely high safety profile, and minimal medications and less frequent follow-up. Now anesthetic concerns of the surgery. Surgical anesthesia in pregnancy poses risk to both mother and the fetus because of the altered maternal physiology. And in supine position in the second and third trimester can induce profound hypotension due to aortic and vena cava compressions of the uterus. Even the airway management is hard in pregnant patient with because of the breast enlargement, weight gain, and laryngeal edema, and the risk of gastric acid aspirations are always there. So there are general anesthetics, but most of the eye procedures are done under local anesthetics. With the bupivacaine, it has been found to cause bradycardia, and it has been grouped under Group C. Lidocaine is a local anesthetic which has been categorized under Group B, is fairly safe in this group of patients. So surgical positioning and safety measures should be considered while we're taking this patient for the surgery, like rotating the patient's hip, abdomen, and thigh while maintaining a normal head position for ophthalmic surgery. And for maternal safety, uterine displacement ought to be considered to prevent systemic hypotension. Nil per oral technique should be followed to reduce the risk of gastric aspirations in mother. Then intraoperative non-invasive fetal monitoring should be considered while we are considering this patient for surgery. Now, intra and perioperative medications, mitomycin C and 5-fluorouracil, which usually we use as intraoperative antimetabolites in glaucoma in glaucoma surgeries, they are contraindicated, but the risk of subconjunctival administration is not known. So antibiotic of choice in pregnancy is erythromycin, then analgesic is acetaminophen. Corticosteroids, though it is classified under Group C, topical steroid can be used in pregnant or breastfeeding women. So atropine and phenylephrine. These are atropine is classified under group C, and it can cause CNS and severe depressions. Anticholinergics can even cause reduction in breast secretions. In phenylephrine especially, the 10% can cause maternal and infant hypertension. And use of phenylephrine should be cautious, especially in the first trimester, because it can cause reduction of blood flow to the placenta and means reduction of blood to the fetus. So punctal occlusion and eyelid closure should be considered. So stage-wise management plans are to be done in case of pregnancy conditions like preconceptional counseling, then should be monitored and in each and every trimester till the lactation period. So the preconceptional counseling, if the patient is diagnosed with a glaucoma and is preparing for pregnancy and others, we can counsel them for laser or maybe MIGS surgery so that the patient will be free of the medications throughout the pregnancies. So again, we have to explain the benefit and risk of the anti-glaucoma medications on the fetus, the importance of punctal occlusions. We have to establish the baseline IOP and visual field examinations, the effect of pregnancy on intraocular pressure, and the need of frequent follow-up should be explained to the patient. Also, need of possible laser and surgical intervention if the medical management fails should be explained to the patient. So in the first trimester, which is a period of organogenesis, we can discontinue the medical management if the glaucoma is stable and in a very early stage, or we should reduce the number or frequency of the medications. So if the pressure can be kept under control without treatment during this critical period, close monitoring of intraocular pressure and visual field would be of an ideal approach. So after baseline investigations, follow-up protocols should be followed at least once every trimester in mild to moderate cases. In advanced cases, brimonidine can be added in first and second trimester. So systemic carbonic anhydrase inhibitors should be considered only for short-term IOP control when in a very severe conditions, and surgery is best avoided in the first trimester. In second trimester, there is a decreased risk of fetal malformations. And brimonidine remains to be safe first-line medication even in second trimester. Beta blockers, if we start, careful monitoring of fetal growth and heart rate should be considered. Now, systemic acetazolamide can be considered only in case of refractory and severe cases, and second trimester is the best phase for interventions like laser trabeculoplasty or surgical interventions. So third trimester, in first trimester, the fetal exposure during this phase have direct bearing upon the neonatal complications after the birth. Brimonidine is absolutely contraindicated in late trimester. Beta blockers and carbonic anhydrase inhibitors are ideal medications to be used in this period. But fetal growth and heart rate monitoring should be done if the patient is kept on a beta blocker in peripartum periods. Prostaglandin analogs are avoided. And the newer anti-glaucoma medications such as latanoprostene, guanide should be avoided, and natarsudil, because of its tocolytic effects, should be better avoided. And during the labor-associated Valsalva can cause elevation of IOP and accentuate the glaucoma damage, and may also result in damage of thin blebs in trabeculectomy operated patients. So this condition can worsen if the labor gets prolonged. So the cesarean section can be safer. Even in cesarean section, the bundle pressure tend to cause minimal raise in IOP, that is about 3 to 4 mm, but it is not recorded. So during lactations, beta blocker and carbonic anhydrase inhibitors may be used. But if beta blockers are given, the baby beta blockers are best avoided in congenital heart disease and any pre-existing cardiac or lung problems. So use of topical carbonic anhydrase inhibitor and systemic carbonic anhydrase inhibitors are considered safe in lactation period. PG analog, because of their short half-life, it is considered safe if it is given after the breastfeeding. Brimonidine is contraindicated. So take-home message for the management of glaucoma in pregnancies are glaucoma management in the childbearing age group is challenge for both the patients and ophthalmologists, needs multidisciplinary approach by ophthalmologists, opticians, neonatologists, and well-informed patients. Pregnancy provides natural protection in majority of cases by lowering intraocular pressure, but some patients are always at a risk of progressions. The treatment plan depends on the stage of the pregnancy, severity of the disease, and safety of the procedure. No anti-glaucoma medication is considered absolutely safe. Surgical intervention is opted only in high risk or uncontrolled progressive disease. Thank you.
Thank you, Dr. Tara, for that wonderful exposition of a very challenging situation, a situation for which there are no clear-cut guidelines available to us. So you very nicely highlighted that how our management strategies have to keep changing through the different trimesters. What I learned was that brimonidine is the most safest drug in the first trimester, but it is contraindicated in the last trimester and during lactation. So that was a pointer for me as well. So with that, we move on to the panelists. If anyone would like to add something, I would request you to please give your perspectives or comments or any challenge that you have faced with such patients, any practical pearls or tips that you could draw from your experience.
The challenge that I have faced is that by the time they come back to us, they're already in their second trimester and they might have been exposed to these drops. So counseling of women of the childbearing age and explaining to them that this can have an effect even before they are pregnant is very important too.
Yeah, true. Dr. Techi, please request you to stop sharing your screen. Yeah. So if any of the other panelists, we have a question in the chat box not related to this, but which is the safest drug to be used in the pediatric age group? Dr. Vikram?
The brimonidine is contraindicated absolutely till the age of 2 years. Preferably, we should avoid till the age of 6, 7. So other drug, prostaglandin, dorzolamide, everything is okay.
Everything.
Unfortunately, the pediatric glaucoma is not a medical disease. Majority of the time, they require surgical intervention. So of course, but we can give dorzolamide, prostaglandin. Other than brimonidine, everything is okay.
Okay. Thank you.
And the second thing is, as Dr. Vikram was saying, that the patient comes late and we have to counsel. But if the patient, fortunately, they are very small segment of the population, pregnant women having glaucoma. But if they have glaucoma, and if they come in the first trimester, you foresee the thing that you have to stop medication. So whatever the treatment, you should try to do in first 3 to 4 months, surgical intervention. So SLT, we can do SLT is very safe. The mix, of course, we can try because even if they work for 6 months, 1 year, they will take care of the period we don't want any medication. So these are the things we should take care.
Thank you. So I think if anyone would like to add something, otherwise we'll conclude the webinar. So we've had some very fruitful discussions. I thank all the panelists for sharing a wealth of information and giving their expert comments and perspectives. All the speakers had very informative and comprehensive talks. So thank you all so much for your presence. I thank our panelists, Dr. Gursatinder Singh, Dr. Rajul Parekh, Dr. Vikram Jain, and Dr. Hussain for their presence here this evening. Before we leave, I'd like to share that these talks will be available in the AIOS YouTube channel. So if anyone wants to refer back to them, you can always go back to the YouTube channel and see them. And also, I'd like to share that this is an ongoing program. We have a continuum of talks. So there'll be more such talks next weekend, that is on Saturday and Sunday. So look forward to having all the PGs join us again then. So with that, thank you once again and a very good night to all of you.
Right.
Thank you.
Thank you.
Thank you. Good night.
Thank you, ma'am. Thank you.